Hello everybody, welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today we have a couple special guests with us. For all the YouTube watchers out there, I'm going to acknowledge the camera up there, not in a very photogenic way, but hello to everybody watching on YouTube. Today we got, again, special guests. I'm pretty pumped for this episode. This is something I feel like we don't talk about enough, that we need to get out there and we need to be more open with. And I'm joined by our safety DICO, all things vaccination, mental health related, Sean Simmonds from here at MCHD. Sean, why don't you tell the listeners, I'm giving you the reins here because this is definitely your baby and you put this one together, and this is not my area of expertise, but this is one of the more valuable topics, if not the most valuable, that we've had on in some time. So tell the listeners about our guest and tell the listeners where the genesis was for this idea and how you put this one together.
Yeah, so I appreciate kind of handing over. I feel honored to be a part of your podcast. This is a big deal. But May is coming up by the time we have released. Will be in May, and that is the National Mental Health Awareness Month. And I think it's important. Part of my role is working on mental health for the district and for cooperating agencies. So that's across the region. I think it's important that we kind of bring it to the forefront. We make it known that the more awareness we can bring to mental health and mental health issues and the stigma, the better we are as an agency and as peers, and we can work together to increase our wellness. So talking about Mental Health Awareness Month, started in 1949. It was designed to increase awareness for mental health issues, as well as celebrate the recovery of those that have been battling the affliction. And then looking at EMS professionals specifically, as far as suicide deaths in the industry, we have 5.2% is what's published versus the 2.2% of suicide deaths in other professions. Pretty alarming statistics. And then whenever we look at mental health disorders specifically, you look about 27% of EMS professionals are going to battle some type of mental health illness, whether that be addiction, depression, bipolar, ADHD, across the board. And that's saying that if you're having a crew change of 4 people at your station, one of those 4 people is battling some type of mental health illness. So it's not hidden, it's not rare, it's out there, and people that are battling some type of mental health illness. So I thought it was important that we celebrate Mental Health Awareness Month, and we could do that with the podcast and with the Podcast 360, and we can bring out some special guests that are professionals in the industry. So invited Justin Farris. He's the PIO amongst many other things for the Cypress Creek Hospital, Behavioral Health Hospital in Harris County. So Justin, thank you. Welcome.
Thank you for having me. I'm glad to be here.
Justin, why don't one of the things that you do out at Cypress Creek, or the thing you do, I guess, is you coordinate and run the Honor Strong program.
Sure.
It's a dedicated unit. Can you tell us what the Honor Strong program is and what you've been doing for the industry?
Yeah, so we started the Honor Strong program back in 2018. Actually, it was right after Hurricane Harvey happened. It just kind of fell in our lap. We weren't really prepared for it, and all of a sudden we started seeing a bunch of EMS dispatchers, police officers, firefighters starting to show up with, present to the ER with psychiatric issues. Then we started kind of digging into the problem a little bit more, and we realized there's actually a pretty significant prevalence of mental need for mental health treatment for this population. The biggest problem we ran into, though, was making it to where it was something that was comfortable for them to come to. One of the biggest stigmas in mental health is for first responders. They're worried about losing their job. And so when we wrote the program, we basically catered to that. We made it to where it's confidential, it's private, there's a whole process for everything, down to where we have certified first responder counselors. We handpick our staff to make sure that they're in tune with the type of situations that you run into every day. I will say that we have seen, since COVID, a significant increase in EMS admitting to the hospital, mainly with major depressive disorders or stress-related disorders. With kind of COVID throwing that on top of that, just kind of throwing everything, into gear, I guess, basically.
Total disarray, right? Like
pretty much
everything lifestyle-wise. I've heard both y'all bring up stigma, and just I'm gonna interject here real quickly, and hopefully this discussion, you know, I think Sean's goal, your goal with what you're doing with the Honor Strong program is to break down that stigma,
Sure.
right? And the stigma that A, it's not common, B, it's something you should be ashamed of, C, it's something you're gonna lose your job over, those sort of things. And I wanna get into how we handle that here at, here at the hospital district as far as confidentiality and having access and encouraging access for our folks, because, those three things are probably the most important pieces to this puzzle from a,
Sure.
an EMS provider, paramedic, first responder standpoint, is that, again, 1 in 4 are gonna deal with this, double the rate of suicide. This is not, you're not alone. This is not uncommon, and there shouldn't be a stigma. If you've
Right.
got an asthma flare, there's no shame in going to the doctor and getting your inhaler refilled. If you're going through COVID and PPE and Hurricane Harvey and the ice storm and all the things that we've gone through over the past few years as emergency care providers, whether it's medics or firefighters, ED nurses, ED docs. I mean, there was 2 new emergency physician suicides just in the past week that I've seen make the round on social media. So
we actually expanded our program to include frontline healthcare workers probably about halfway through COVID, when we started to realize we started having ER charge nurses walk straight in front towards the hospital and say, hey, I want to kill myself. And okay. So, I mean, and one big thing that we've done too is, like you said, the confidentiality piece of it, is we wanted to make it to where it's not even a question if you're going to have confidentiality. And we work with each county, with each department, each district, to make sure that your job is not affected. That's not our goal at all. The goal is to make sure you have somewhere to go back to work. And right now we have a pretty successful rate with that.
And the confidentiality, I'd say, is such a huge piece, especially for people that are seeking help, from an agency standpoint, from administration. Whenever you have somebody that's coming up to you and saying, hey, I'm having these issues, one of the biggest things that you need is that trust. You need the trust that they can open up to you, they can have a safe haven to reach out for, they're not gonna be disciplined, or, you hear people say, put the target on their back.
Mm-hmm.
That's such a huge thing. You have to instill that trust in your crews. And then whenever they do come up to you, turn that trust around and fulfill it. So I know at MCHD, whenever we have somebody come up to us and we say, hey, I'm having these thoughts, I'm having a really hard time with this, I've had these stressors, I need some help. One of the first things we say is, okay, this is between us. It's not going anywhere else besides the people that need to know to get you taken care of. Here are the steps we can take, here are these resources, and understand that nobody else outside of this room is gonna know about this unless you decide to tell them.
Right.
So we put this back on them, saying, hey, celebrate your recovery, celebrate your trips, your improvements, but don't feel like you're pushed into it. This is completely up to you.
So I'm gonna go back to something you just said, and Justin just said, and I'll kind of tag on the end of Sean's there. If anybody listening out there has worked with Sean, it's obvious within about a nanosecond that confidentiality and treating this disease process with respect, just like you would any other, is this is Sean's foundation and what he does every day. So we're lucky to have someone like that here. If you're in a listening agency somewhere else, and you want to learn from someone and learn from an example, Sean's open and available, and get with him offline, because this is what he does every day. And I think the crews out there, I know the crews out there would echo that it's not just this is not just empty words. This
Sure.
is the way we manage it here at MCHD, and that's the foundation to having folks accept that program, is, again, not feeling like that target is there. If the charge nurse walks into you, Justin, and I'm suicidal, that's you've already gotten to the end point there. You know what you're having to deal with.
Right.
And that's when things have progressed. That didn't come in 5 minutes. That's a progression over probably days, weeks, months.
Sure.
Correct?
Sure.
So we're on the truck. I've got my partner, my chief. I've got the people that I work with every day, and COVID's bogging me down. We've got PPE stressors. I've got some exposures, high risk, you know, the hospital wall times are long, you know, we're short-staffed, we don't have enough in-charges, all the things that we've been going through here at MCHD over the past year are starting to weigh on me. What are some warning signs before we get to that, you know, I'm the end of the rope and I'm suicidal?
Right.
What are some things you could see in yourself, coping with stress, problem signs, and then problem signs you could see in your partner? So taking
Okay.
it from both directions, like you're looking inward and also looking at the people
Sure.
around you. What are some of those warning signs?
I mean, a lot of it has to do with the partner too. I mean, if you've been with somebody a long time as their partner, you're going to notice that there's a change in them most of the time. But sometimes you're not. I would say some of the things that to look for would be, you know, loss of feeling safe, extreme fatigue, you know, inability to control their emotions, starting to get burned out, or just direct suicidal ideations. And those kind of go hand in hand from what we've seen so far during COVID. That kind of goes in line with what we've seen as far as EMS personnel goes, as kind of our top 5.
See, that burnout word is such a huge thing. Like I feel like whenever we hear someone say, "Man, I'm burned out," that's like, "Oh man, this is big." How can I recognize burnout in myself? Like I know there's been several times whenever I'm sitting on the truck or sitting in the office, and I'm like, "Man, I cannot do this." So like if I'm on the truck right now, what is something that I would see in myself to maybe help myself recognize that I'm hitting burnout? Is it?
I would say probably like lack of empathy, of, you know, not moving as fast as you used to, not having as much care as you used to, probably making common mistakes that you wouldn't normally make. Fatigue is always, I think, kind of going to be part of that too. And then I'd say probably, you know, different ups and downs emotion-wise.
That'd be a big tip from like a supervisor or a media supervisor to say, you know, you've had a crew that's been great. They've had no issues. They've always been doing, kind of extra mile things, and then suddenly they're on the radar. They're making the common mistakes. They're not making their response times. They're not, they're forgetting their uniforms. That whatever the issue is,
Right.
As a supervisor, you should probably take notice of that and be like.
I mean, if you track a lot of that data too, you can kind of tell with your consistent people, if they're always consistent, then all of a sudden their numbers start to fluctuate. That could be a sign, and at least something to look into, especially if they're always consistent.
Yeah, that's the first question I feel like we try to ask, even from a clinical side, right? Not just operationally, punctuality, uniform, truck check, those sort of things that may be the sign to the soup. But even if you're in on a run review from the clinical side as a medical director, hey, is everything okay? Everything okay at home? How are you doing? Do you need help? That's got to be your first question before you start pointing fingers, right?
Right.
And that lack of empathy and the loss of empathy is, to me, more obvious from the outside. In other words, I'll see it, and if I know
Sure.
you all as providers, then I see you patient blaming, angry at patients, arguing with patients. That's, in my experience, has been easier for me to see in others than it is in myself. Oftentimes when I get to see it in myself, and I think we all have varying fluctuations with burnout, and it's definitely a spectrum and a gray zone, and any time that you're in the stressful world of providing emergency health care and all the things it involves, as a medic and, as an emergency physician, probably have to expect a little bit of that. But when you start having difficult interactions with patients, you start bickering with patients, start having, not even the patient complaints, just like, I used to go through the shift and not get mad at folks, and now I'm mad at every third patient, or every third patient is mad at me. Maybe time to look in the mirror a little bit. And sometimes it's hard to do that when it's you. Sometimes it's easier for me to say, hey, Sean, last few shifts have been rough. Everything okay? Just a little bit more turmoil than usual. And that's a tough conversation to bring up, because you've got to sort of call somebody out a little bit, but you've got to do it in a caring way. I'm not sure that I'm an expert there.
I mean, camaraderie is a big part of it too, and you also have to have approachable leadership, I would say, to where if they identify that, they can come to you about that, knowing that that's something that they can talk to you about.
It leads us nice into your next one there on the list. So,
I mean, you were saying one of the first signs is your partner's going to notice something's wrong with you. So if I'm on the truck with you, Justin, and we're going, I notice that you're getting short-tempered, you're sniffing at patients, you're starting to have these confrontations and maybe signs of burnout. What are some things that I can say to you? What can I say to you? And then at the same time, what should I not say? What should I avoid saying to you?
I mean, to me, I don't know if it's really, and from what I've heard from anybody that's been through our program, it's not necessarily about what you say, it's about what you do, how approachable you are and how available you are, basically. No one really has to be called out, I wouldn't think, or to be told maybe, hey, maybe they're not at 100% on top of their game. But I think it's always being that person that, having that comfort level and then being able for, being approachable for them to be able to talk to you about it. And just being like, hey man, what's wrong with you? You okay? You're not on point like you used to be. But if you don't have that trust and that comfort level, why would I tell you?
So, what on the opposite spectrum, or when we come up to it, or when we walk into the shift and we see someone that's going through this, what is something that I should absolutely? I mean, one of the things that I hate hearing is just get over it. That's something that absolutely drives me insane. What are there other key terms or words like we should absolutely avoid for somebody that's going through either a crisis or burnout or?
I don't know. I'm a big believer in being just blunt, straightforward, and honest.
Yeah.
And just making it known what's out there. Be like, hey man, there's stuff out there that can help, and it's not gonna jeopardize your job.
Right.
If you need it, here's this package for you.
So at some point, whether the partner's open to receiving help or opening up to you, if it starts to impact operations, clinical care, and you start having some concerns of your partner's safety, your own safety, and the patient's safety, you're gonna have to raise that concern up to a supervisor level.
Sure.
What should we look for? What are kind of triggers that we should look for before we make that reach or reaching up to the chain of command?
I mean, there's a couple of things you can do, and it's something we've kind of implemented lately too. Is we're doing a huge tele-assessment launch and kind of expansion. So that may be something that you can include. Hey, why don't you talk to this person real quick and just kind of get assessed, off the record and see maybe you're not where you thought you were. Maybe you're not identifying some of the things that are the issues. I mean, that's always an option, but I mean, I think if you're looking at it from that whole, if you're looking at a general overview of everything and you're seeing all these signs and everything's making sense and you've got this incident making sense with this and this not making sense with this, you basically painted a picture of there's an issue and now it's time to take it to that next level. Say, hey, why don't you, let's go look at getting somewhere and at least getting a diagnosis if there's one there.
Yeah, I know here locally we have a lot of resources. I mean, we have the partnership with Cypress Creek, we have a partnership with Tri-County, we have our EAP services. We have a lot of therapists counselors that have reached out and offered to be kind of available for us. What are some other type of resources that we should look into if we're talking about counseling or therapy? What's the difference between those two? And then if we're talking about medications, that's such a gray area. And I this is one of the things that I dread working with people with mental health illnesses, especially on the truck, is they say, oh, my PCP gave me this list of medications. When should we be comfortable talking to our PCP, and when should we probably dive into a specialty like a psychiatrist?
I mean, psychiatrist is usually going to be for crisis situations for the most part. If it's something that needs to take it to an elevated level when you're not, if the therapist won't help, or if they need a medication adjustment, or really, I mean, if they're just like, hey, I'm really suicidal. A psychiatrist helps at that point because they can, work with the department, make sure that they get the right assessments done, make sure they get the right medications done, make sure medications aren't interfering with other ones that they may have, which happens a lot. So, I mean, I would say if you're seeking out therapists, seek out somebody that is a first responder background, that's relatable to you. I think that's the biggest thing is if you're talking to somebody that have no clue, they haven't lived your same experience, it doesn't really generate that much trust for it. So you want to have somebody that understands where you're coming from and has that kind of background and is certified in it. We required our therapists when we first opened the program to be certified first responder counselors, which they had to go through credit hour programs and do ride-alongs and all kinds of stuff, and they had to have a background in either prior military service or a first responder.
So there is a difference between a normal civilian counselor versus a first responder certified counselor.
Yes. Yep. I mean, you have to pass an exam. You have to get certified, licensed. You have to be a master level clinician.
Yeah, I'm tagging on a couple things there that you mentioned. One, out of all the negative that's come from COVID, which Sean knows as well as anyone else, there's an avalanche of negative from COVID.
Sure.
There has been some silver linings, and one of those for me is the push forward and the increased availability of telehealth options.
Right.
And from a mental health standpoint, you know, in my own personal experience, when you're down, when you're anxious, when you're really struggling, sometimes just the act of making that phone call, scheduling the appointment, clearing that time out of your day and driving to that appointment, whether it's, you know, psychiatry, counseling, some combination, that's too much of a hurdle. Or at least it has been for me in the past personally. That's just like,
Right.
I can't get there. So to have telehealth options to at least broach the conversation, that's a huge increase in availability, increase in ease of access. So when you're really just, you know, apathetic and you're burnout, you're depressed, you're anxious, you don't want, you know, your executive functions are not running on, you know, full steam, you're not gonna organize a Tuesday at 9 and figure out on your day off how you're gonna, you know, what are you gonna do with the kids, how are you gonna get to your appointment, you know, how are you gonna schedule it, when is the opening, I don't wanna pull my calendar up, all those things that actually have to happen for you to get there.
Right.
Having a telehealth option is huge, especially if you're just coming off shift, if you've had a difficult run, if you've had a, you know, a pediatric death or, you know, some patient interaction that's been very impactful. Having that telehealth, I would, especially the MCHD listeners out there, we'll include all the information that we've talked about and all these access points in our show notes. But I would encourage everyone, you know, if you call them up and you talk through something and you find out that everything is okay and you make it into your next shift, so be it. But you may catch yourself kind of at that cliff edge there too.
Right. And so something that, just want to piggyback off that a little bit, that's also allowed us the opportunity to make our PHP and IOP virtual. So which ease of access has increased significantly with that. We've actually expanded our Honor Strong program to a PHP and IOP program as well.
Spell out the acronyms there just for the listeners.
Partial hospitalization program
Okay.
is the PHP, and intensive outpatient program is the IOP. IOP is usually the step down part of from PHP. PHP is more intense, and you actually get to see a psychiatrist. We try to step everybody down from the inpatient side to the PHP side. You get a lot of, that's more of a treatment side right there. If you're inpatient, that's crisis stabilization. You're in 100% crisis right then and there. We deal with the crisis, but then we also deal with the treatment.
So
at that point too.
just for listeners' knowledge sake, and this is, as an emergency physician, this is probably an area where I should be more learned, but when someone comes in and they're suicidal to the emergency department and they've got a plan, they've got access to firearms at home, and they have a mental health history, you know, those patients pretty clearly, pretty quickly are going to get placed in inpatient care.
72-hour hold, yep.
Period, the end, and until they're stabilized, just what Justin's talking about. But that's going into inpatient care or going to a clinic visit, those are
Two different extremes.
and they're far apart. And in the middle, there are other options, and that's partial hospitalization and intensive outpatient treatment that Justin's talking about. And those are situations where, you know, I know some programs you go in for 8 or 9 hours a day, and then you go home and sleep in your own bed.
Right.
Or you have multiple recurring visits with your counselor or your psychiatrist over several days in a row to try to step things down. And having, you know, I just learned something. So being able to have partial hospitalization and intensive outpatient care via telehealth, that's a game changer.
It's a big part of the confidentiality piece of it too. So the program is separate from our regular outpatient, general adult and adolescent. We have a separate confidential part for the Honor Strong program. Law enforcement officers take pretty good advantage of that. We don't see any of them really in-house for the outpatient program. They'll all be virtual. But that also opens it up to not just immediate people that live in our surroundings. It opens it all the way for, you know, down to Fort Bend County, Galveston, out of state. Insurance covers 100%. So it makes it very easy.
That really, I mean, that's an expansion, right? You don't have to drive in, you know, it's easier to arrange childcare, it's easier to arrange all the other grocery trips and everything that you have to do. I would, second piece I would plug in there from personal experiences, if you know, having first responder trained counselors and therapists is, and that's huge. If you're listening out there and, you know, you want to talk to somebody about your stresses, and again, and they have no idea what it's like to work at 24, what it's like to, you know, code a pediatric patient, what it's like to, you know, witness all the stress that we do every day. That's a gigantic advantage. But if you go in with a therapist or a counselor and you sit down for that 30, 45 minutes and you walk out and you feel like, he or she didn't get me, try another one.
Right.
It's not a cable contract. You're not signed in for 3 years, and if you break it, you gotta, you know, pay 2 months rent, right?
Well, and the PHP program really is there ideally to catch before you have to go, you get to that point where you have to go inpatient.
Right.
We don't really want anybody to go inpatient because that means you're actually actively in a crisis. The PHP side of it is really to catch and to start the treatment then before you get to that point. So I agree with that for sure.
And I've had folks where I've had really good relationships with and felt like I could really share. I've had others where I felt like, it's just not a good match. And it's not personal.
Right.
It's just, you know, you're gonna sit down and share your fears and your anxieties and the things that make you, you know, not sleep at night and make you angry at your kids and angry at your partners. Like, it needs to be somebody that you have some sort of connection with. And there's not a good way to know that off the bat. I don't feel like. How do you feel about that, Sean?
You know, I've had, when I was on the truck full time, I had my share of critical incidents, and, you know, I had my issues coping. I had confounding stress, especially when I was coming into the industry. You know, I didn't understand the thoughts that I was having. I would have, you know, kind of stress breakdowns on the side of the road after a bad car accident or after a bad pediatric call. And then so whenever I started expanding into that, I thought, man, maybe there's something into this EAP. Maybe I should reach into this employee assistance program and talk to somebody. And I had some poor fits. You know, I had some very, very poor experiences with counselors. And I built up a wall. I thought, man, that's not for me. That's not my thing. And then, you know, a few more bad calls later, I started having those thoughts again. I would have nightmares. I would have, you know, the trouble sleeping, the trouble adjusting at home. I'd be lashing out. And so I got tagged along to another counseling appointment with somebody else in the family. I was like, man, I do not want to go to this. I didn't like my outcome. I don't want to be part of this. I walked in and I had, you know, probably within 5 minutes, you know, I walked in with the thought of she's gonna read my thoughts. She's gonna get in my head. And then the wall was broken down. I felt like I was offloading years and years of stress. And within an hour, I felt like I was a new man. Like, you know, I had all these thoughts that I didn't know I was still having. Right. I had all this stress that I didn't know I was still holding on to. And then it's just finding that one right person, that right counselor, that therapist, that person you can talk to that really understands you, can work up a plan for you that's realistic. You know, it's not like somebody that's going to come in and say, okay, you're not allowed to think this anymore. No, you're going to have these thoughts. Whenever you have these thoughts, what do you do with them? You know, how do you continue on through your day? And then what's your treatment plan moving forward? Maybe they want to see you twice a week. Maybe it's once a week. Maybe it's once every other week. And then just like the program in the hospital, it's stepping that back and working down. So I'm thankful that for me, I found somebody and I share that with everybody. I say, hey, this person worked well for me. And then I follow that up with, they may not be great for you. You know, you may have to follow up and find somebody else because it's just the person that worked for me and my personality. So I absolutely agree 100%. You got to find that person that works for you.
Right. And we also track quality outcomes data and clinical outcomes data. I think we're the only hospital in Houston, or Houston Psychiatric Hospital was that it tracks all the way through, you know, from admission to discharge. We use something called the Basis 32 for the Honor Strong program. So we use that to make sure that we're actually hitting on the right stuff and that we're actually doing what we're supposed to be doing. We're actually making progress. And if we're not, then we fix it. So
it's incredible to follow the statistics too, to be able to say, hey, there's this success rate. Mm-hmm. There are outliers that don't work out, and you know that's going to happen with everything. Sure. Just as like cardiac or back problems, sure. Every other illness, you're going to have those things that are going to restrict you from work. But the vast majority, you're going to have a positive case and return to work and a healthy lifestyle afterwards. Mm-hmm. You're going to be better because of it.
And I would think with the expansion of the partial and IOP, that would be more significant.
Yeah, and my own personal experiences led me, you know, I guess as a, you know, mid-40s, you know, male, a lot of this stigma was ground in, you know, from a young age, you know, that talking to someone was quote unquote a weakness, and, you know, like you said, you know, suck it up, you know, get over it, those sort of things. That's very commonplace throughout most of my life. And sometimes I feel like that I listen to others talk and others that are struggling, and they feel like that there's a single pathway to, or you're gonna go see a counselor, then you're gonna go see a psychiatrist, and you're gonna go be on medication, and it's gonna be this long ordeal. And I see it more as almost like house cleaning. You know, I think in our job, we should probably expect that we're gonna have to deal with stress relief and, debriefs and, counseling appointments. I almost think it should just be the expectation. And not everything is leading to intensive outpatient treatment or hospitalization or, suicidality for that matter. I mean, it happens, and it's double the national average, so we need to be aware of it. I don't want to minimize that end of it, but sometimes it just may be a couple counseling appointments. You get some things off your chest. You talk about, mindfulness or meditation or deep breathing or exercise or whatever, all the other non-pharmacologic things you can do for stress relief, and then maybe you're okay. So you're not buying into some, long-term ordeal necessarily. You may have, some folks have more baggage and more things that they have to unpack than others, and some people's problems run deeper. But some people go get their inhaler, they use it every now and again when they wheeze and exercise, and they're not on chronic long-term steroids for their asthma, for example. So there's wide variability there, and sometimes one of the resistance points that I see in folks is that idea that I'm gonna go down this path and it's a never-ending path and I'm never gonna get off this road. When in all reality, you may just need to clean out your closet a little bit. And that may be all that it takes for you to get back some of that empathy, to get back in some of those other healthy habits. I'll put my quick plug in here for, Sean does it in every critical debrief that I've been a part of with him, and that's, diet and exercise and sleep. It's way easier said than done as shift workers. Substance use and abuse is prevalent. It's been there, done that.
Sure.
It's and not that we're talking about abstinence here, but if your stress relief is 3 cocktails, probably not healthy. Good sleep is important. Good exercise is important.
Right.
Doesn't mean you have to be a marathoner or an Iron Man or Iron Woman. Just some of those things, and the literature supports that.
Yes.
As far as, depression and anxiety, and exercise is, on par with SSRI. So get out and get your fresh air this time of year. That's really important. I would put that on my list of things that I tell myself I'm taking my medicine when I don't want to get out and exercise. So I think those things are important. What else you want to add, Sean?
Dr. Patrick, I would agree 100%. It doesn't have to be you're at a crisis or you're going into a crisis or going into a mental health issue. Having those maintenance appointments, just if you had nothing going on, you're just like, and I feel like I'm just in a rut. Schedule that appointment, go talk to somebody and just kind of work it out. It could be telehealth, it could be in person, and you just say, hey, this is how I'm feeling. We can talk about it, let's get through it, talk with that counselor. And then they can work out some plans where you say, okay, well, maybe you go for a walk, maybe you do this. It doesn't have to be that you're at that point. It could be a resilience, kind of a maintenance visit, and then you come out and you say, okay, here's some things I can work on myself, and you can move on from there. It doesn't have to be at that point.
No, I mean, that's kind of what we cover, everything from, we probably opt to cover everything from the inpatient crisis stabilization side all the way to the IOP. Because really at that point, it's more of, here's some resources for you, here's some tricks, here's some tips. We're not gonna make you get in a group and hug and sing Kumbaya and cry on each other's shoulders. I mean, that's one of the big things we've seen too, is like, well, I don't wanna go cry in front of everybody. We don't have to. That's fine.
So Justin, I'm gonna carry off of that and say, if we've got people on the truck right now, they maybe they didn't run a bad call, they didn't have a bad day, they're maybe arguing with their spouse, or they're not getting along with that partner. There's a whole bunch of interpersonal conflicts that can add stress to your day.
Sure.
So that person that's on the truck right now, we have a lot of listeners, a paramedic, it could be on a fire truck or a squad car for a law enforcement. What is some easy things that they can do right now to try to reset their day? They can feel a little bit better, they can have a better outlook, and they can have some plans to work forward.
I would tell them to look up some, anything resiliency based. We're a resiliency based program. So anything along those lines is kind of ideal. I mean, I agree with what you said about the exercise, sleep. For stress, that's a big part of it. But I would just find what works for you, and if it's something you don't think you can handle on your own, then there's other options out there to help.
And we're happy to take, you know, if you have links or
Yeah, I'll
things-
make sure and get you
things
some.
that y'all typically provide from a resiliency standpoint. I'll put my quick shameless plug in. I do not get paid from the company, but I've had personally good success, and corny as it may sound, I use the Headspace app on my phone. It's a fairly inexpensive and kind of one-time fee mindfulness app that you know, you can do sessions in as short as, you know, 5 to 10 minutes, and there's, you know, all kinds of different roads you can go down, and when I get kind of that feeling where things aren't right and you feel like you're sliding a little bit, it's worked for me.
Right.
I go in phases where I'll use it a lot, and it usually is centered around family stress. You know, family gets crazy, that's when I need it the most. For some reason, my kids stress me out more than my patients these days. I guess that's the way it goes as a parent, but, you know, so that would be, you know, if you check out Headspace, again, you can snicker and laugh, but it's definitely helped me out some.
What we can do, we can provide a list of what we've seen work
Sure.
best for
That'd be
the
great.
program, of it, like our wellness, so personal wellness, anything, that safety, trauma. Sure.
What's your go-to?
I like to fall back on like the Code Green campaign. It's very veteran, it's first responder centric, it's got a lot of good resources for us, and then just reaching out to peers. I think the biggest wealth of knowledge is the person next to you that's already gone through it.
Absolutely.
And like I kind of hinted at the beginning, we don't publish, we don't say, oh, this person did this, so if you need somebody, go talk to them. We don't do that. You know, that's part of our confidentiality. But if you do, or if you're having issues, there's a very high likelihood that the person sitting right next to you on that ambulance, right next to you on that fire truck, is going through that same thing, or they have gone through, or they know somebody that's gone through it. So reach out, say, hey, I'm having a hard time sleeping. I have nightmares, and you know, maybe they'll come back with a joke. They'll be like, oh, ha ha ha. And you're like, no, really. I mean, I'm having a little bit of issues. What do you think I can do? Oh, okay. Well, let's do this. And I would encourage, if you're on the opposite end of that, if you're on the receiving end of that, you know, be that reach. And if you don't know where to send them, then say, I have no idea. I'm not the person to talk to. Here's this person. You know, don't turn them away. Don't chastise them. Don't make them feel bad because how they are, but be that resource.
Right.
And MCAC listeners out there, if it's not your partner, if it's not your suit, Sean is, for better or for worse, available 24/7 at his own detriment. So
My wife can attest.
you've
I'm
always,
the exact same way, so I understand.
you've always got Sean. And on that note, you know, again, thanks Sean for putting this together. Thanks Justin for coming. I would encourage all of our local listeners out there, and national listeners for that matter. Honor Strong program it just sounds tailor-made for, you know, what we're talking about. May Mental Health Month. This is, you know, Sean laid it out at the beginning. This is something that 1 in 4 of us are going to deal with. Probably more than that, because I'd say that number's underreported. You know, double suicide rate. Let's break the stigma down, break these walls down, and I think if we talk a little bit more about it and we're open with each other about it, then that's the obvious first step. So thank both of y'all for coming. I didn't do any work today other than sit here and jab. This was all these two, so thank both of y'all. Thank y'all for listening on YouTube. Subscribe to our YouTube channel. As always, if you have questions or concerns, ideas for future podcast at mchd-tx.org. It's where you can reach us. Leave us a like, leave us a review wherever you listen. We always appreciate it. And as always, thanks for listening. We'll talk to everybody again soon.